how good the human is, you could have the best cardiologist in the world. They're not going to be able to see everything there is to see on a 12-lead EKG. And it turns out that the AI algorithms can identify higher risk patterns. And so what they can do is they can identify patients who are higher risk, who we may not be able to identify as higher risk. And they'll say, hey, look out, this is somebody who, may be at risk for an MI or a blockage. And it's something that we wouldn't catch based on our normal assessment of the EKG. So I think that's where we're headed. We haven't rolled that out yet. We're still mostly using our own ability and our own intuition. But I think in the very near future, and we're studying this now as part of a research project, to see if using the AI can make us better at identifying high-risk patients and sending the right patients to the cath lab and not waiting, too long for patients who we feel are, lower risk.
Mm-hmm. So what about surgeries themselves? Well, AI, that was a plot in Chicago Med a few years ago where they put in this giant AI machine in the operating room, went rogue.
Like robotic?
They had to shut it down. No, he was telling them what to do, but somehow they overlooked the system. It was a TV show.
Yeah.
But will it be in the operating room too, assisting surgeons?
I think so. I can't comment on cardiac surgery directly because I'm not a cardiac surgeon, but I do spend some time in the cath lab, where we place stents and valves. And I think where it's helpful there is I think we're going to get to a point where, they do, and probably many of you have had diagnostic angiograms or stents, I would imagine.
Sure.
And so we're going to get to a point where they do a diagnostic angiogram and we see a blockage, right? We see a lesion that needs to be fixed. And on that screen, they're going to show exactly what kind of stent, the size of the stent, and the number of stents that need to be placed. And it's going to be algorithmic. The software is going to identify the length of the blockage, and it's going to essentially suggest the right stent to the cardiologist. And I'm guessing that most of the time it'll be correct. So it takes the guesswork out of placing stents.
And less preliminary testing of things too. Because a lot of times you have to go through 2 or 3 tests for evaluation, particularly with the valves, to do the measurements, that type of thing. So the time frame will be shorter too to be able to get the procedures done.
Yeah, and actually on that note, these days, many of you probably are aware, we have non-invasive CTs that can actually diagnose blockages. So, in the not so olden days, 10 years ago, 5 years ago, my colleagues and I would order stress tests every time a patient had chest pain if we thought they were lower risk. These days, I still order stress tests on occasion, but more often than not, I will opt for something called a cardiac CT or a coronary CT, and that will actually show you the full anatomy of the heart vessels, and it'll show you exactly where the blockages are, how much the vessel is blocked. And these days, on the topic of AI, it can identify high-risk plaques, so it can tell you, oh, this particular lesion is a softer plaque, and it's more likely to break off, and so you should watch out for it, or, this is a higher risk blockage. And so it's really amazing. All of that is done non-invasively. So that is a CT scan. And so I often opt for that particular test because it's shorter and in my opinion, it gives you more information than a stress test.
So AI is going to come into play in preventive cardiology. I mean, we especially for those many of us in the club have family history of heart problems. Sure. So we've already got the first prerequisite, and so when we get to the point where AI will be able to tell us before we start having the pain that we're going to have the pain.
I don't know if we're going to get quite to that point, but I will just say that we have a lot of wearables now, many of which are widely used. They can pick up on early signs of a heart attack. So whether that's an arrhythmia, whether those are extra beats like PVCs, PACs, whether that's just an increase in your heart rate. We have a lot of clues that can sort of tip us off. And we have data now that when an Apple Watch, for example, identifies an abnormal rhythm, an irregular rhythm, 80% of the time it's picking up the real thing. I mean, it's real atrial fibrillation. It's not perfect, but it's pretty darn good. So I think we are going to have a lot of early signs of these things. But at the end of the day, as we were talking about before, you still got to listen to your body. And if something feels different, something feels abnormal to you, then you should get that checked out and not delay. There is such a thing as what's called stable angina, and that means, patients who have known coronary disease can have occasional chest pains here and there, and that is to be expected, especially with predictable levels of exertion. But once that gets out of proportion to your norm, or let's say it takes you less time to get those symptoms or less distance, that's called unstable angina. And that's when you should think about seeking care.
Are the wearables getting better? We've talked about those in years past. They're certainly marketing them like they can tell you everything.
Yeah, my wife just asked me if she should get that Aura ring,
Oh, yeah.
it looks pretty cool. I went online, looked at the price. I said, I don't know. But no, I mean, I think that there's value in them. And I've certainly been able to identify abnormal heart rhythms, for example, for my patients. They'll send me their readings, and we've been able to catch some episodes of AFib. I think they're getting better, and I think it will be even better if we're able to link them with our health record, so that when a patient comes to the office, or even when they don't come to the office, we get some kind of alert when there's an abnormality. So I think that's the next step. But and I understand some health systems around here are already doing that. So they've linked their Apple Watch data with Epic, for example.
Oh, wow.
So
Can that be done here yet?
not here yet, but hopefully soon. I think they're getting better, slowly but surely. Yeah.
As we were discussing when you walked in, one of the challenges for a lot of heart patients is which pain is which. And do I need to go to the emergency room? Am I okay?
Yeah.
And if something could address that, that would really be a giant breakthrough for a lot of us. But it doesn't sound like we're there yet.
Yeah, I mean, I don't think AI is going to solve that problem.
Okay.
AI it's not a panacea for everything, but I do think that anything that feels out of proportion to your normal, even if it's your new normal, should be paid attention to. So I do often hear, patients, for example, who have, especially my older patients who have known coronary disease. Maybe they have 60% narrowing here, 50% there. We've been treating them with aspirin and statin for years. It is expected for them to, at times, especially with maximal exertion, to have some degree of pain. That's called stable angina. But once that becomes, let's say, for example, normally it takes them 5 blocks to get any sort of symptoms. And now all of a sudden it takes them 2 blocks. Or even worse, they're getting pain at rest. That's concerning to me. Any kind of pain is concerning to me. But when it gets worse than their baseline, that's when I'm concerned. And we treat that, as something called unstable angina. And we take that just as seriously as we would a heart attack. So we would want to make sure to get an EKG and a set of enzymes. We would want to see that patient in some sort of medical setting.
Now, is this helping with what your initial question was?
It's very good. One question is it's probably the concept of pain, right? And then there's this kind of absurd distinguish between again, most recently, upstairs, the sixth floor, started having some discomfort in the scalp, and then it radiates little things. And it's not painful. It's discomfort. It's discomfort. It's uncomfortable, and also it resonates. When I initially had some issues, and I'll communicate with my cardiologist, and basically, I guess it's maybe very similar to what your narrative was. If it increases intensity, then you should go.
Yeah, I mean, if I may ask, when was your event?
I had four to few months. So 4 interactions, surgeons after 30 downtown. Initially, I had my symptoms were just time space continuum. I'm sure I'm at probably about 20 months ago. I was running and I felt tension in my shoulders and kind of radiating. I knew that was generically potentially something. Everybody in my family has heart disease, parents, grandparents. My dad died here about 6 months ago.
Oh my gosh, I'm sorry to hear that.
88. In any event, I don't want to believe it's about me, but so that was my cardiologist didn't ask me to do it. Echo stress test, which I think would have actually been very clear that I had flu shots. But he looked at he did other things along the lines of that initial
CT?
Yeah, I think CT and some other imaging. And a year later, I was in there.
You ended up having a bypass surgery? Or a stent?
Stents.
Okay.
The widowmaker was fully included, and then I think they put in 3 that day, but Dr. Foote was way more complicated, and he just find some real time for you, and so there was that, and then there was a couple more.
I see. Yeah, I mean, I think your story highlights the fact that early attention is always better. You always want to take your symptoms seriously. It does raise sort of a bit of a flag when you say your symptoms are similar to what they were before.
Yes.
Right. I always pay attention to that because you know your body the best. And so you said, and your stents were now how many months out?
The last round of stents was in October.
So 4 months, 5 months out here. So yeah, I mean, I think that if you were if you were my patient, I would want to do some form of testing. Right? It's not too early to do some form of testing. You could either do a stress test if it seems like your symptoms are happening more with cardiac rehab or with exertion. So technically, you're doing a stress test every time you're at cardiac rehab. That's the point of cardiac rehab. But if you want to do a more formal evaluation, you would do an exercise stress test in the office. Or now speaking about these CTs, the technology's gotten so good that we can even image patients with stents. So particularly at our, I'm not trying to advertise or anything, but at our Glenbrook location, we have a CT scanner. It's called a photon counting scanner. It's very fancy. And it can actually image through stents, so we can tell you if the stent is open or closed. So you have options. And it's hard to say if we're going to find anything or not, but it's better to be safe than sorry once again. Again, I don't know all the details. So I don't want to say exactly.
I get it.
I think an extra test is generally not a bad thing.
Someone else is new in cardiology. Oh, we have a
Somebody might
question.
have a
Oh,
question.
go ahead. Turn on your microphone. Unmute yourself, too. There you go.
Yeah, okay. I couldn't tell if you were talking to me or somebody else. Um, my question is, well, one of them is you mentioned various clues. I think you were talking about EKGs, that there could be a problem in the future, and I was wondering if you could talk more about what the clues are.
Yeah, definitely. Um, so, as medical professionals, physicians, PAs, APF, we're trained to see the classic patterns, right? So you might have heard of ST depressions, T wave inversions. There's something called Q waves, which suggests that someone may have had a prior infarct. And then there's, of course, the dreaded, what we call STEMI. That's the ST elevation that suggests a full occlusion to an artery. So those are all classic findings on EKGs. That's what we all look for. But there are more subtle clues and subtle patterns that can show up. One that comes to mind that we can see with our human eye if we look closely is something called R wave progression or R wave progression. So on an EKG, the voltage should go from, in the leads V1 through V6, the voltage should go from all the way down going in V1 to all the way up going in V6. And that's a normal pattern. But if it's slow to transition, if you have more downgoing complexes, that can suggest that you have some sort of a blockage or narrowing in your anterior circulation. And so that's a clue that we look for. Now, with regards to AI, it can see certain patterns that we just can't recognize with our human eye. There's a number of sort of blips and patterns. And what it does is it's trained on, let's say, hundreds of thousands of EKGs. And it knows that this EKG was normal or ended up having a normal course. And this EKG ended up going to the cath lab and getting a stent or having a total occlusion. And so when you take 100,000 EKGs and you combine that knowledge and you recognize certain patterns, there's patterns that I can't recognize with the human eye, nor can my colleagues, but the computer can. So that's the power of the computer. It is a little bit of a black box. I know I'm not giving you probably the detail you're looking for, but it's because I don't recognize all the patterns either. And I think, as providers, we have to be humble enough to recognize we can't see everything. So we have tools that can help us. And so there's, like, as I mentioned, there's a tool we're investigating to see if we were to use this tool, would this make us better decision makers? And would this end up in better outcomes? And so, we'll let you know when those results are back, but there's a lot of promising data available that they can make us better decision makers.
Does everybody understand what the EKG is? It's the electrocardiogram. So it's basically looking at the electrical impulses going through the heart from different angles. So you get all the stickers put on, and then there are usually 12 leads, and they're all kind of combined across the heart to show different impulses of energy when the heart is squeezing. So does that make sense? Anybody have any questions about that?
Excuse me, other questions from home? Go ahead, Belinda. Turn your microphone on. Unmute yourself. There you go.
Okay. My question is regarding when to get additional imaging. I had 3 stents placed. It was a family of very strong family history of heart disease. Mostly the men. I'm the only female at this point, if that makes a difference or not. And everything in my history was good right up until I started having chest discomfort just across the collarbone, which I thought was more stress than anything. It ended up I went to the ER, went immediately the next day for the angiogram and angioplasty. That was 3 years ago, 3.5. Luckily, I've been doing really well. I'm on the same meds as I was back then because I'm doing so well. But I'm just curious, do you recommend any additional tests to be done, after a certain time period, without any strong symptoms? Should there be another CT scan or another, I mean, I have an EKG, but anything other than that, any other kind of scanning that should be done just to make sure everything is still good?
It's a good question. In the old days, not so old days, 10 years ago, they used to do stress tests every year. And we found that after a while, that was a bit of a waste of medical resources because, 98% of the time we weren't finding anything new on those stress tests. Okay, but it takes half a day to get those stress tests done. I would say, and may I ask, on your ultrasound following your stents, was there any abnormalities on the ultrasound that you're following?
No, none at all.
Okay, well that's great. That means you came at just, definitely at the right time. You may get a different answer from different cardiologists, but if a patient is doing well after a stent and they're taking all their meds and their cholesterol is well controlled and they tell me that they're active and feeling fine, I do not feel compelled to get annual or even every 2 years echoes or stress tests. I find that to be unnecessary testing. Now, I'm very attuned to any subtle changes in symptoms. So maybe a patient says, well, I've been feeling more tired recently, or I've been feeling like I can't quite do what I used to do. That is enough for me to get a test, right? So maybe I'll get an echo, or maybe I'll follow up with a stress test in that patient. But a patient who's doing very well and whose risk factors are controlled, I personally do not recommend testing every year. So hopefully that answers your question.
Yeah, it does. It's been 3 years now. And he did try to, shortly after I was in rehab, and about halfway through rehab, I started having some discomfort again. And they did another angiogram and discovered I do have a small, very small artery that they think is probably the problem, but it's too small. They don't want to do anything about it, so I'm on the ranolazine. He did try to take me off of the ranolazine to stop it, and I started having some discomfort again walking. I was timing it. 10 minutes out, I was having some mild discomfort. 7 minutes out, put me back on the ranolazine, and it's been gone ever since. I've not had that problem since then.
Yeah, what you're describing is something that we encounter a fair amount. Is sometimes you'll have narrowings of very small vessels or very distal vessels that really are not amenable to stenting because they're so small. And so in those cases, we often will treat with medical therapy, okay? And we call that sort of microvascular disease or just very distal disease. And so ranolazine is an example of medical therapy. And other examples of medical therapy would be isosorbide, which is a long-acting nitroglycerin. You could also just use regular sublingual nitroglycerin for those symptoms. Some patients do that. Like I said, we also have long-acting nitros, like isosorbide or Imdur would be the more common name. And then ranolazine is usually second line, but it's great that it works for you because if it works, then that's the right medication. So that's a great learning point for everyone, I think.
Yeah. Yeah. Well, thank you. That eases my mind about, not having any more testing done as just to get a jump on something that might be down the road.
Yeah, yeah.
Other questions from home? Go ahead. Go ahead.
Another question. What makes something a heart attack or not a heart attack? Is it that some tissue was killed by not having oxygen, or are there other things that could distinguish it?
That's a really good question. And I get asked this question by the coders all the time who ask me to document appropriately so that they can, of course, bill appropriately. I wish I didn't have to answer it so often, but I'm happy to answer it in this setting. So what makes a heart attack a heart attack is a mismatch in supply and demand of blood flow, right? So we have two different kinds of heart attacks. One is an occlusive heart attack where you have a full blockage of an artery. That is generally called a STEMI or a complete occlusion. So I think that's what you described earlier. That is a classic heart attack, but that's not the only kind of heart attack. We have patients who come in who do not have full occlusions, but do have a lack of blood supply to their heart muscle. So think of it as supply and demand. The heart is demanding a certain amount of blood flow, and there's not enough supply there, okay? And so there are many examples of a non-occlusive MI, or NSTEMI, which is a technical term, where there's a leakage of cardiac enzymes because there's not enough blood flow to the heart. And that is also considered a heart attack, okay? And that also often requires a trip to the cath lab and often a stent. Even though it's maybe only 70 or 80% occluded, it still requires that treatment. So anytime you have a lack of blood flow, I would consider a heart attack.
What about damage to the heart itself? I know that came up for me, and I said, well, there was no damage to the heart. That's the good news. So that's not the definition of a heart attack. So what causes the damage to your heart?
A prolonged lack of perfusion or blood supply will cause what's called an infarct, right? So a scar in your heart and an inability of that muscle to pump as well as it should. And so we see that often on an echo or an ultrasound, and we call that, again, a technical term, a wall motion abnormality. That's a technical term for part of the heart muscle is just not pumping the way it's supposed to. And sometimes that's reversible. So again, if you get there within an appropriate amount of time, maybe 48 hours, you can restore blood flow and that muscle goes back to doing what it's supposed to. But sometimes if you wait too long, let's say somebody waits 3 days or 4 days, that heart muscle has now infarcted. So it's become sort of a scarred down muscle. And unfortunately, even if you put a stent in and restore some of that blood flow, the damage is already done. So that's when you end up with a little bit of a decrease in function after the heart attack.
So that's more serious than the other things.
It has more long-term implications, so the patient would need to be on additional meds to strengthen their heart. Right, it's a less favorable outcome for sure.
Other questions from home before I jump in again?
I have one more.
Go ahead. Go ahead.
It's not necessarily about heart attacks per se, but my son had like 35. I worry about him because of the family history of heart disease. My dad died at 35, my cousin at 36. Since he was in his early 30s, he's now 42. He has had high blood pressure, which they call essential high blood pressure. Do you think that worries me, of course, under the circumstances, but do you think AI will at any point in whatever you do help to better identify the reason for that?
Well,
And does that lead to a heart attack if it's
yes.
controlled?
Yeah, so essential hypertension is a risk factor for a heart attack, certainly. it's generally at that if it started at that early age, it's generally more genetic predisposition. So, like you mentioned, you have people, many family members with heart disease and high blood pressure. He's more likely to have high blood pressure. If that's well controlled, then that shouldn't put him at uh, increased risk. Well, what would put him at increased risk would be if it wasn't controlled, or if he never got that under control, and that's certainly a risk factor for heart disease. In terms of AI, I don't know exactly what role AI plays here. I mean, we will have more sort of wearable blood pressure monitors, so we'll be able to, send you home with a even like a blood pressure sensor. It won't necessarily be a cuff. It could even be a watch or something like that to monitor your blood pressure. So we'll be able to identify early if the blood pressure is uncontrolled. But like I said, AI is not going to solve for everything. I think probably we'll get more insight from your family history than from the AI in that particular case.
Okay, all right. Thank you. Yeah, because he's not overweight. He's never smoked. It's just genetic, I suppose, as you were saying.
Most likely, yeah, most likely. And of course, there's some element of diet and lifestyle. But if it started that early, it's most likely a genetic predisposition.
All right, thank you.
One of the real revelations for me as I've been involved with hearts is how many families are affected by heart disease. I mean, I think everyone in the group has a family history of heart disease. I know I do. And I've talked to my children about it, older adults, say, take care of yourselves, get your heart checked. I don't think it can happen to you because I had my first stent, they gave me all the medications, everything was fine, and then 5 years later, I needed another one. At that point, they said, well, it's heredity. And so I worry about my children too. I think they're thinking about but it's fascinating to me how many families are impacted by it.
I was going to say that because of my father's heart disease, I had an early, okay, at that point in time, decades ago, it was recommended, my physician recommended me starting to take cholesterol medication in my early 20s. It's a prophylactic. And I was, I don't know if it helped or not. I've had a lot of surgery since, but I'm also reflecting on my daughter, and who's younger, and where's the science on prophylactic, hereditary, for now, chronic.
Yeah, I mean,
interventions.
yeah, I think in familial high cholesterol syndromes, when your cholesterol is sky high, even in your youth, there's very good data that you should start statins early. Okay, and so I think if given your history, your daughter should be screened for high cholesterol, for blood pressure, for all the risk factors. And if indeed she's got very elevated cholesterol, then I think there's good data for starting early. Now, you have to be a little careful with young females because in women of reproductive age, you should not be on a statin if you're planning to get pregnant. Right? And I always remind myself of that, when I see a young woman. And so you have to be careful, and you have to ask them what their family plans are. They plan to have children. If they do, I actually will wait to put them on a statin. But if they're out of that range, then I think that the data would support starting early if she had the appropriate risk factors. Some people say statins should be in the water. I'm not quite in that camp, but I can see where they're coming from because the data is overwhelming that the lower your LDL, the lower your risk of heart attack and stroke. You wouldn't know it if you came to my clinic because my patients tell me all the things that they've heard that are wrong with statins. but most of it is hearsay, and I don't want to get into that right now. What I can tell you is that the literature, the trials, the data support statins for heart attack and stroke prevention. And also after a heart attack or a stroke, the data is overwhelming that statins help reduce recurrent events.
Are there AI studies going on of all the data? I guess we're all wondering, like, when will we get to the point where we finally figure out why this is hereditary for a given family? And
Yeah.
that's the kind of massive project AI is supposed to tackle. Right?
Well, we do have something here in Denver Health. I would be remiss if I didn't mention it, called the polygenic risk score. Okay, and that's something you can get. I believe it's. I do believe it's still out of pocket pay. It's something like $200, maybe a little less than that. But you can essentially provide a saliva sample, and it will give you a full polygenic risk assessment of your risk, not only for heart disease, but for various types of cancers and metabolic diseases. Really, it's a multi-organ sort of test. And there's one of my colleagues, Dr. Kumar, who's really a pioneer in this. And he's published some papers that have shown that when you combine this polygenic risk score with other traditional risk factors, you can predict the risk of heart attacks considerably better. So it's much better than just having your cholesterol or your blood pressure. If you have this, to also pertains to some of the questions from before, questions about children. If you have this additional piece of information, your prognostic ability is much stronger. You can be more proactive. So I don't know. It may be something I consider getting for myself, just so I understand my risk a little bit.
Yeah, he's my cardiologist. We'll talk about that.
What's that?
He's my cardiologist.
Oh, Dr. Kumar.
The one we talk about.
He's excellent. Yeah, he's a brilliant guy.
He is always so upbeat. I express all these doubts that we've been talking about. You're fine, everything's great. You're looking great, everything's great.
He's a modest guy, but he's published probably more than 150 papers, trained at MGH with some of the leaders in cardiology. And he's constantly pushing forward clinical trials. In addition to being an excellent interventional cardiologist, one of the few interventionalists who also does peripheral arterial disease, so he'll put stents in the legs and in the lower extremities when necessary. Really an incredible clinician.
What's his name?
Kumar. Last name is Qamar. Armand is his first name. He's a few years ahead of me, but he's really an inspiring colleague.
He has offices in Skokie if you want to try to get him.
He placed my stents. I love him.
Okay, good. Another fan.
He's presented here.
Mm-hmm.
I think he actually may have done it on hypertension, but he's had a lot of involvement with the polygenic risk factor
You really brought it to
studies. Yeah.
That's his thing. So you talked earlier about we're not doing stress tests every year, and I actually remember that because I had my first test in 2012. I did that the first few years, where I did a stress test every year. Are there other changes in treatment we should know about? We touched on aspirin before too. Isn't thinking changing about that too?
Every week.
I'll just touch on aspirin real quick. For patients who have known coronary disease or prior heart attacks, there's no debate about aspirin. Everyone should be on a baby aspirin because it puts you in a totally different category. The debate exists for patients who have not been diagnosed with coronary disease, who are still preventive patients. And the thought is that if there's no evidence of coronary calcium and there's no evidence of coronary disease, the risks of the aspirin may actually outweigh the benefits in that very healthy population. And so aspirin's not for everybody. It does slightly increase your risk for bleeding. It can affect your kidneys. However, I would say most of the patients in this room, most of the people in this meeting very much benefiting from aspirin, and there's no debate about that. As far as new therapies, I mean, where do I even begin? So you want to talk about valves or coronary disease,
Well, what's going to affect the most people?
yeah, there's new therapies in the pipeline almost every week. I mean, if we're talking about purely medications, it seems like every few years we get new medications to lower the cholesterol. There are patients who can't tolerate statins, right? So for those patients, we have injectable alternatives like PCSK9 inhibitors. So you may have heard of Praluent or Repatha. Those would be options that are very good at lowering cholesterol very quickly without having to be on a statin. We've had additional agents now that are, targeting certain receptors in the LDL particles that can also lower your cholesterol. I'm thinking of a medication called inclisiran that's already available. And in the pipeline, we will have additional medications that will target certain types of cholesterol particles. So you might have heard of LP(a) or apolipoprotein B. These are types of cholesterol particles that increase your risk. I think very soon, in the near future, we're going to have treatments. I think they exist, but they're not on the market yet. That can target these high-risk particles. So that's coming. We could spend a whole hour talking about new therapies for valvular disease because there's so many new things on the market. Minimally invasive mitral valves, minimally invasive tricuspid valves, clips that can clip the valves together, whether it's the mitral valve or the tricuspid valve, have all been recently FDA approved. All of these things did not exist even 3 years ago. So, it used to be that you had a leaky valve, you just get started on diuretics, and you're treated with diuretics for the rest of your life. Now we can actually go in through the veins, put a little clip in that valve, and stop the regurgitation. Now, this is for a select patient population. It's not for everybody. It's certainly not for mild regurgitation. It's reserved for severe symptomatic regurgitation. But there's so many exciting things, available now, and almost all of them are available here at Endeavor. You just have to talk to the right person, and you have to qualify it. But if you meet the criteria, every year there's new FDA approved devices that can help heart patients, and it's really an exciting time to be in cardiology.
And there's a lot of things that I work with in heart failure that are monitoring devices that are actually implants to help prevent people from getting so symptomatic that they end up in the hospital. So you get, and you're notified by certain levels, certain pressures in the lungs and things before you get fluid overloaded, which is what tends to send people to the hospital, so we can treat them at home before you end up having to be in the hospital for a number of days. So it's fascinating.
Anybody at home have anything that they've been through that they want to hear the latest on? We've covered some of them. Michael, no questions today?
No, sir.
No, we just mellowed out from being away.
We got one here.
Oh, yes, go ahead.
So since my initial surgery 15 months ago, I was also which changed changed my life in certain ways. The biggest change in my life is the diagnosis of my aorta is mildly enlarged at the mid to second portion. So I used to be a serious mountaineer all around the world. I used to bench 300 pounds. Now I can't lift more than 40 pounds. I can't do push-ups. I can't sprint. This is what I'm told. Is there a resource that can help me for people like me out there, like what can you? It totally affects my. It was totally that was the the diagnosis that make me most imbalanced. Is there some resources online about the culture of people who have what it means to be to have this diagnosis?
Yeah, so I mean, you're referring to aortic dilation, which when it gets to a certain point is then called an aortic aneurysm. I think that to fully answer your question, I would need to know the details of the degree of dilation, because there's a very big difference between somebody with an aorta of, let's say, 4.1 centimeters, which is just above the threshold for a male, which, to be quite honest, if that's the case, if it's very mildly dilated, I would not recommend all of those lifestyle changes. And there's a very big difference between somebody who has an aorta of 5 centimeters, which is bordering the threshold where we would consider surgery, or or 4.9 centimeters, which is like 2 or 3 standard deviations above the norm, where we're trying to do everything we can to prevent that from rupturing, right? So it's hard for me to give you exact guidance, but I think if you're talking about that upper category of aortic aneurysm, then I'm sure that there are support groups out there for that particular type of patient. But there's different flavors of aortic dilation, so I don't think it one size fits all. Right? I don't think one size fits all.
And sometimes they try and just be a little bit more preventative because they say don't lift more than 40 pounds because they know you're going to go. So probably 40, 45 is okay. I can do 50. In reality, you could probably do that much and just kind of lower that.
Right. It's prophylactic, right?
So hard to do. And I would really press whoever your cardiologist to say, is this, are these restrictions absolutely necessary, or is this, like Debbie said, more
kind of wiggle room?
Yeah, is there wiggle room here? It really depends on the size of your aorta.
How hard did you push them into it? Because you're being monitored there. Part of that is to get you comfortable.
Yeah, no, I mean, I know, and that's the beauty of the confidence level that cardio rehab people, it's really very important. So now I'm done, but I also, I know for my cardiologist and then working with, Evanston, like, if I go walk on, on the golf course with snow, I'm gonna start, getting my heart out there. But I know I can't go past this. I can't go past. This is the range so I'm watching the range the whole time. It's really, I can still go walking, but I know what my range is, and I can't, and I shouldn't. I need to slow down once I start getting to the max.
Anybody at home deal with this? We haven't really talked about this. I don't think it's come up before. Well, we just need to talk to your cardiologist. There's stuff on the Mended Heart site too. I'm going to give you my card.
And a lot of times I tell people, if you're getting more anxious watching your watch or your heart, try not to do that quite so much, because that anxiety is just going to make your heart rate go up, make your blood pressure go up. Sometimes you just need to kind of sit down and I'm like, take a deep breath.
Mm-hmm.
Listen to your breathing. It is okay. This is a stagnant thing. It's going to not tell you you're feeling good or feeling bad. It's just going to give you a measurement. You have to listen to kind of internally how you feel, and just like we were talking about the maps, not all, technology is great. I always tell people, do you feel bad inside? Is something off? Are you not feeling right? Don't worry about your watch. Because I've had a lot of people who are like, oh my gosh, my watch says my heart rate's 140. You know how to check your pulse. Count your pulse and see if that's right, because this isn't 100% accurate.
Right. There's the beauty of deficit rehab. So constantly reconciling the two.
Yeah, they're monitoring.
Yeah, no, it actually makes me feel more comfortable. I don't want to be an idiot and the daughter, and I make things worse, right? I actually really very much enjoy having some reference point, not relying on my self-referential. I have somebody else. I don't really have that much trust in me.
People are usually pretty good about you know, boy, I feel a little off, or, you know. Dizziness, that's another thing, you know,
Yeah.
and somebody asks, are you dizzy? You're like, turn my head real fast, yeah, I get dizzy. But it's kind of having that internal, you know, monitor to say something feels off. And that's when you should listen.
Any final questions from home?
Yeah.
Everybody feeling good? Okay. Well, great. Well, thank you, Dr. Summers. This was a great session.
Thank you.
Thank you.
Thank you.
Thank you very much.
Both of you.
Very informative.
Mhm.
So March is
March is cancer and cardiology. That's the one that Sherry asked for. We'll see you all in March, everybody.
Okay, thank you so much.